Afternoon, ladies and gentlemen. My name is Sibarashe Chigayo. So I'll be taking you through the fetal anomaly study. So, so the study is usually performed between 18 and 22 weeks of pregnancy. The anatomy of the fetus is checked systematically from the head to the toes. So you might begin from the head up to the toes, or you might begin from the toes up to the head. So sometimes if you check the fetus from the toes, if you see any abnormality, then it might help you to anticipate what you are expecting to see as you are scanning up to the fetal head. So in terms of technique, it is wise sometimes to understand how the fetus is lying within the mother's tummy. So you might have a general sweep whereby you might just check how the fetus is lying within the mother's tummy, whether they are facing, whether they're in breech presentation, they're in cephalic presentation, they're facing downwards, they're facing upwards, or they are facing to either the mother's right side or the mother's left side. So this will help you now to identify the structures that you might want to assess. For example, in this image, we know that if the child is lying within the mother's tummy in cephalic presentation and facing to the right, you are most likely to get the fetal face if you put your probe on the mother's right side. Then if you are to put your probe on the left side, you are most likely to get an image of the fetal spine. Then obviously you are going to get an axial image of the head on the distal part of the mother's tummy. So the head, for assessment of the head, two axial planes allow visualization of the cerebral structures relevant to assess the anatomic integrity of the fetal brain. So with the transventricular plane, and then we have also the transcerebellar plane. There's also a transthalamic plane that we can also use, especially to measure the fetal head circumference. But from these views, we might be able to see most of the structures, especially those that we also see in the transthalamic plane. So this one is the image that we get for the transventricular plane. So this is the position that we are examining, and this is the position of our probe. So the first thing is to assess the shape of the head. So we assess the shape, and then we assess the size of the head, and then we also assess the density of the skull bone. So for the size of the head, as previously discussed, we put our size on a nomogram. Anything below the 10th center will be small, and anything above the 90th center will be large. So large for gestational age, we might usually see it in cases of ventriculomegaly, where these ventricles become dilated, or where there is overgrowth of the fetal brain tissue. Then for the shape now, the shape should be oval, the head should be oval in shape. Any alterations in the shape of the head, like in cases of a lemon-shaped head, then it might be associated with pathologies. For this one, maybe spinal bifida. And then we might have a strawberry shape or a clover-leaf shape, which are associated with trisomy 18 and trisomy 13 and thanatophoric dysplasia. Then we also assess the density of the scalp. So the skull bone should be continuously echogenic. So it should be continuously echogenic with only breaks at the suture lines. Then if we do not see this continuous whiteness, or when we get to a point of clearly seeing the fetal brain, then we might begin to suspect that there is poor mineralization of the fetal skull, which we usually see in osteogenesis imperfecta. Then we move on to the internal structure. So we should see a midline flux dividing the brain into two. And then this is the parietal occipital fissure. It is at this point that we measure the ventricles. So where these points is the area that we want to measure our posterior walls of the lateral ventricles. So we put our caliper from the internal margin. So it's inner to inner. Our measurement should be from the inner margin to the inner margin of the ventricle. Anything above 1 centimeter, we consider that to be ventricular omega. Then we also want to see the corpus CP. We rule out any cysts. And then we also want to see the cavum septum pellucidum, which is a rectangular structure. Failure for us to see the cavum septum pellucidum might mean agenesis of the corpus callosum. So if you don't see this, you also look at the shape of the ventricle. So in agenesis, the ventricle might appear like a teardrop. Then from the transventricular plane, we rotate our probe towards the fetal's back, where we now get the transcerebellar plane, but maintaining this region where we see the cavum septum pellucidum. So even in the image that we assess the cerebellum, we should also see the cavum septum pellucidum. So for this image, we also assess the shape of the fetal head, and then we assess the cisterna magna. So it's a fluid-filled space behind the cerebellum. So we measure from there, from the outer margins of the vermis of the cerebellum to the inner margins of the skull bone. Then anything greater than 1 centimeter, we consider that to be a dilated cisterna magna, omega cisterna magna. Then there shouldn't be any communication. There's a fourth ventricle that lies somewhere over there. We usually don't see it when it is normal. So we shouldn't see any communication between the fourth ventricle and the cisterna magna. If there's communication, then we begin to suspect gender war. Then we also assess, we should see the two hemispheres of the cerebellum and the vermis in between. Then we should also assess the thalamus. So this is the thalamus that we can also assess in the transcerebellar plane. Then we also assess the falx and then the cavum septum. Then we move on to the fetal face. For the fetal face, we want to assess the shape of the forehead. So we shouldn't see any protrusions as what we see in proboscis. This is common in holoprosencephaly. Then we shouldn't see any flattening of the forehead as we see in microcephaly, trisomy 21, and we shouldn't see any protrusion of the forehead as we usually see in thanatophoric dysplasia. Then we should also see the nasal bone. Failure to see the nasal bone might be a soft marker for a chromosome in trisomy 21 usually. Then we should also assess the maxilla. Any gap in between the maxilla, a defect on the maxilla bone might be an indicator of cleft palate. Then we also have to see the mandible and rule out micro or retrognathia, which is micrognathia, which is a short mandible. Then, like in this, is demonstrated in that image. Then from this view, we then go on to assess the fetal orbit. So if you manage to get an image of the fetal mid-profile sagittal view, you just rotate your probe from there 90 degrees, and you will be able to get an image of the fetal orbit. So when we assess the fetal orbit, we want to look for the presence of the orbit. So sometimes they might be absent in cases of anorexia, or they might be, the size of the orbit might be small in cases of microphthalmia, or we also assess the distance between the orbits to rule out hypotaylorism or hypertaylorism when the gap is too wide. Then we should also see the length and rule out any cases of cataract. So these are some of the images that you might then see whereby there is reduced, increased space, and then here they are cataracts. Then from the image of the orbit, you just slide your probe distally slightly, and then you'll be able to assess the palate. And these are tooth buds. And from this image, we can then rule out any cleft palate. Then we move our probe into the coronal plane, where we see the fetal nose, the upper lips, and the lower lips, and we rule out any cleft lip. Then from the fetal face now, we then go on and assess the fetal heart. So in terms of technique, the next, I think Dr. Lerenga is going to demonstrate the technique in terms of assessment of the fetal heart. So the 4 important views that we want are the 4-chamber view. We also want the left ventricular outflow tract, and then we also want the 3-vessel view, and then the right ventricular outflow tract. So to begin with the 4-chamber view, so for the 4-chamber view, sometimes it might be wise to begin from the level of the abdomen so that we can identify the position of the stomach bubble, or rather the situs. So as you move upwards now, when we draw an imaginary line from the spine of the fetus, which is somewhere over there, up to the upper anterior abdomen, we should see the heart occupying more of the left side. So 3/4 of the heart should be more on the left side. Then if we are to draw an imaginary line that bisects the heart through the intraventricular septum, then the angle in between should be at least 45 degrees plus or minus for us to say that the situs is, the axis is normal. Then as we are assessing the heart now, we should see the tricuspid and the mitral valve freely moving, and then the tricuspid valve should be a little bit more apically offset. The offset should be more apical when compared to the mitral valve. Then we should also assess the right atrium and then the left atrium. There's a foramen ovale that opens into the left. Then we also assess the right ventricle, and there's a moderator bend. So the morphologic right ventricle has got a moderator bend. And then we also assess the left ventricle, which should be more apex forming. And then when we come to the left atrium, we should see the pulmonary veins entering into the left atrium, and below we can see the aorta, and we shouldn't see any vessels in between. Then from this view now, we move on and then go on to the left ventricular outflow tract. So for the left ventricular outflow tract now, I think my videos. So for the left ventricular outflow tract, this is the area that we are assessing. So we should see the left ventricle and the aorta originating from the left ventricle. Like in this case, we see the left ventricle and the aorta originating from the left ventricle. The anterior walls of the aorta should be continuous with the interventricular septum. And then we should also see the aortic valve freely moving. And then when we then turn on to the right ventricular outflow tract, we should see the so when we move on to the right ventricular outflow tract, we should be able to see the right atrium, the right ventricle, the main pulmonary artery, and then the right and the left pulmonary artery. So this is the area that we are assessing. So we should see the right ventricle, the main pulmonary, and then as it divides into the right and the left. So we should assess the pulmonary valve, which should be freely moving. And then we should also see the aorta now in transverse, because we are getting a longitudinal image of the main pulmonary trunk, and the aorta is going this direction, so it will appear in transverse. So the main pulmonary artery should be slightly bigger than the aorta, and then they will be a freely moving pulmonary valve. Then we go on to the last view of the heart, which is the which is the three vessel tracheal view. So for the three vessel tracheal view, it is this region that we are now assessing. So from the left to the right, we should see the pulmonary artery, and then the aorta, and then the superior vena cava, and then the trachea below. So in terms of, we assess these structures in terms of, number one, the size. So the pulmonary artery being a little bit bigger than the aorta, which will be a little bit bigger than the superior vena cava. Then we also assess them in terms of direction of flow of blood. So for the pulmonary artery and then the ductus arteriosus, here is the area that we are assessing. So blood is flowing out of the heart in this direction. And then also for the aorta, blood is flowing out in this direction. So you'd realize that these vessels would have the same color flow. And then the IVC, because if blood is flowing into the heart, it's in the opposite direction as this. So this one should have a different color flow when we compare it to the other two vessels. And direction of flow should be towards the spine as we are going towards the spine. Then we move on to the abdomen. So for the abdomen, we are in transverse. We want to see a complete rib. We want to see a stomach bubble, and then we want to see the umbilical vein as it enters the portal sinus, and then the adrenal gland. So these are the structures that we expect to see when we are measuring the abdominal circumference. Then our measurement is made at the outer margin of the abdomen, including the skin. So we shouldn't see any double bubble. In cases whereby there's a double bubble, then we begin to suspect jejunal atresia. And a persistently absent abdomen might mean that there might be a problem, maybe in the esophagus, or there might be a problem with the fetal gastrointestinal tract. So in that case, then we also check for the amount of amniotic fluid, and we should reassess it maybe after some time, because sometimes the fetus might have emptied the stomach. Then these are the structures that we just discussed. Then we want to move on. So from this level, we move on distally slightly, then we get to see the condensation. So this is the area where we see the condensation. So we assess the condensation and we rule out any defects, omphalocele and gastroschisis. Then we also examine the condensation at the level of the placenta. So from this view again, still in that orientation, we move distally towards the fetal bladder. So when we get to the fetal bladder, we assess the bladder, the size of the bladder, and we also measure it, and we also measure the thickness of the bladder walls, and then we should also see the umbilical arteries as they encircle the urinary bladder. Then this is now the urinary system, so we then move on to assess the fetal kidneys. So the transverse image, this one, you should always produce this image. In some texts, they say you might then produce one of these two, but good practice would be to produce all of them. So in the transverse image, that's where we can measure the renal pelvis, and it shouldn't be greater than 5 millimeters at 20 weeks. So this view now, the sagittal view, if you are to get the image of the fetal spine, you then rope your probe either to the left or to the right in order for you to get the image of the kidneys. Then from there, we move on to the fetal spine. So we assess the fetal spine from the head up to the distal part where we see the lumbar and the sacrum. So here we assess for any defects. The spine should be continuous from the head. And we also want to assess the skin, which should also be continuous without any defects. There's also an axial view of the spine that we should always produce when doing the anomaly scan. So some other pathologies, you might also rule out kyphosis, scoliosis, which are deviations in the shape of the spine, and also sometimes there might be agenesis of some part of the spine. So this is an open neural tube defect. Then we move on to the extremities where we assess so we should assess all the bones of the lower extremities and those of the upper extremity. So we assess the femur and we also measure it. And we also assess the radius and ulna and we also measure it. And then we also assess the foot. Then we move on to the upper extremities where we have assessed the humerus, the radius and ulna, and also the fetal ends. So in some cases, you might realize that there is absence of maybe probably one of the upper limbs, or there might be amputations that can occur. Then for the foot, we have to count the digits, look for any gaps like the sandal gap, look for any extra digits like in polydactyly, look for any deviations like in trinodactyly. You also look for any fusions of the digits or for any absence of the digits. Then at the level of the ankle, there is club foot that we should always rule out. So for club foot now, it's a structural deformity of the foot and ankle, whereby the supination of the foot is shown in this image. So the foot is turned inward. There's in-foot equinus, which is plantar flexion. And then there's varus of the heel, which is inward turning. And then there's adduction of the forefoot. So the forefoot is adducted. So this is the common image that people present when they say they've diagnosed club foot. But the issue is club foot affects 1 to 3 in a thousand. There is also a high rate of false positive ranging from 10 to 40. This is due to its similarity or the similar appearance that it has to positional foot deformity. So club foot and positional foot deformities like pes supinators may have the same appearance on ultrasound sections obtained in coronal view. So if you get this image, it might not always be a club foot. So sometimes it might be a positional foot deformity like pes supinators. So hence the high rate of false positive. So some of the positional foot deformities that we have might be metatarsus adductus, where there is adduction of the forefoot. So adduction of the forefoot, we also see it in club foot. So sometimes you might see adduction and then say there is club foot, or you might see supination of the foot and then say there's club foot, yet it is positional foot deformities. And then there's the other positional foot deformities, pes talus, where there's extensive dorsiflexion of the foot. So in terms of their prognosis now, sometimes club foot might require surgery post-delivery, and it might be associated with chromosomal anomalies or a genetic syndrome. Hence, at the time of diagnosis, there is need for us to do a chromosomal evaluation. But for positional foot deformities, they are corrected spontaneously after birth. There is no need for surgery, and there is no associated chromosomal or genetic syndrome. So the issue comes to how to differentiate the two now. So as we are doing our anomaly scan, we should always produce a sagittal image from the posterior aspect of the lower leg, and then we should also produce this plantar image of the foot, and then the coronal image of the leg. So this one is the main image. So from this image, we see that there's a rectilinear appearance between the leg and the talus. So they are sort of in a straight line. Then for this foot, so for club foot now, because of the plantar flexion, you won't see that rectilinear relationship. Then for the plantar aspect now of the foot, we check the margins, which should always be straight. So in club foot, you'd realize that there is a four-foot adduction. So there's adduction over there, and this side is sort of like concave. Then in this coronal view, which is the common one, we should only see the long bones and the talus, and we shouldn't see any foot. So if in club foot now, because of the supination, we end up seeing the foot. So all these three images appear abnormal in cases of club foot. Then, according to this paper, they developed this nomenclature. So they emphasize the issue that these are the three main images that we might need to make the diagnosis, whereby in club foot, these three images, there's no rectilinear relationship, there's supination of the foot, and there's four-foot adduction. But for positional foot deformities, you might realize that this one remains normal in all positional foot deformities. And in pairs supinators, there's only adduction, there's only supination of the foot, but the sagittal image is normal, there's no plantar flexion, and the plantar image of the foot is normal, there's no adduction. And then for these metatarsus adductors, there is four-foot adduction, but the sagittal image is okay. There is a rectilinear appearance between the leg and the talus, and the coronal image will be normal. I think.